situation in the Africa region. And to briefly introduce our speaker is in the person of Dr. Michel Muteba. He is a senior epidemiologist and disease surveillance focal point at WHO AFRO East and Southern Africa Hub Office. In this capacity, he plays a vital role in bolstering our emergency preparedness and response across the East and Southern Africa region. Dr. Muteba holds a medical degree from DRC and a Master of Science in Epidemiology and Biostatistics from Wits School of Public Health. He has extensive experience in working with different environments. He served as a clinician, as a lecturer, a researcher, an epidemiologist, and also a technical advisor within DRC and also South Africa. Colleagues, join me to welcome Dr. Michel Muteba. Dr. Michel Muteba, you are welcome, and this is your audience.
Thank you very much, Professor, and good afternoon to all the participants. My sincere compliments to all the seniors who have taken the platform before me. We really learn a lot from them, and we are definitely using them as a model to make sure that we support our continent, build capacity at the same time as we are responding to various outbreaks. So, dear participant, allow me to quickly give you an overview of the Mpox epidemiological situation in the region or our continent. But before that, allow me to give you the major highlight when it comes to the global Mpox situation. So, as you know, Mpox started, we had an outbreak, actually a big one in 2022. And since then, we have 123 countries that reported at least one lab confirmed case. And in total, they have reported from 2022 up to now 109,699 lab confirmed cases, including 236 deaths that have been ascertained among these lab confirmed cases. But just for 2024, globally, 74 countries have reported cases amounting to over 14,000, and including 51 deaths, I think, but we're going to review these numbers. So just for the month of September, we received reports, globally of at least 2,763 lab confirmed cases. So globally, we are 1 month late because we have to receive reports from different continent, different regions. But on the right there, you can see that as in the other part of the world, the other regions that we call WHO regions, we see that the number of monthly cases or weekly cases or new cases are decreasing, but it's a bit different when we look at the African region, where we can see the trend is showing an increase in the number of new cases that are reported to WHO. And here we just want to give you the case profile of all these cases that have been reported globally. On the left, as of the 30th of September, we can see that in the other regions, these cases were actually affecting most males. It's predominantly in males and, of course, in adults. But for the African region, you can see that there is a proportionate distribution between males and females when it comes to the Mpox cases that have been reported. So please remember just that from 2022, we had mostly this outbreak caused by the clade 2B type, which actually, when it came to our continent, affected countries such as South Africa. And on your right, you have the case profile based on individual data that were actually collected. You can see among the respondent, we had close to 85% of them who reported to be men who have sex with men. But I just want to say that for this data, individual data, it's just data that we had from other regions of the world, but we have very, very small data that came from Africa, from the African region. So what I'm showing here does not really show or reflect the true picture of the epidemic that we have currently in 2024 in the African continent, but it's mostly coming from 2022 globally. So they've also identified close to 52% of the respondents who were persons living with HIV. Close to 4% were healthcare workers, and in close to 16%, they had a travel history, and the predominant mode of transmission was the sexual contact, which was identified in 84% of the respondents. So I'm going to quickly also show here, as I was saying, that in terms of transmission type, 492 participants were able to respond here, and we can see that the majority of them reported to have a sexual encounter, and others it's just close contact, human contact. Now, on the right, you can see here that we have the proportion or the distribution of symptoms as reported by these cases that we collected from other regions in the world. So we have, rash, the systemic rash, but also genital rash, which is the third one, the third row. I just wanted to insist on this. Genital rash has been found in at least close to 52% of those who responded. But there are other symptoms, and probably you've heard about one of the cases that we had in Liberia recently, in a child who just presented with conjunctivitis. No skin rash, but when tested, it came back to be a positive case. So we have such cases, and we must not just focus on the skin rash. Now, coming back to, or just coming down to our continent, the situation is just showing us that 19 countries in 24 have reported at least one confirmed case. But in total, we have, as of the 12th of November, 12,186 lab confirmed cases and 53 deaths that have been reported. On the left, you can see a map showing you the distribution of clades as they were sequenced, from different countries and submitted to GZ. And we can see the magnitude of the infection of the confirmed cases as they've been reported. And as I said, 3 countries with the majority of cases in 2024 are the DRC, Burundi, and Uganda. So on this epicurve, we are showing the trends of weekly reported cases in the continent. We have observed the downward trends in the recent weeks, almost 6 weeks, but we just need to be cautious here because we need maybe more time to ascertain actually the completeness of the report. As you know, the DRC is contributing to close to 80% of the cases that are reported on the continent. And just in the last 6 weeks, we have also noticed that there is a decrease in the reports that are submitted at national level. So it's dropped down to below 70% of reports that have been received. But just for the last week, we have seen that on the continent, 427 new confirmed cases were reported.
You want us to listen on the exit?
And in Uganda, we have observed a rising trend. Actually, it's exponential, and there is really a risk of this outbreak escalating further in the country. In the same way that it started in the DRC on the eastern side of the country, it's the same picture now that we are seeing in Uganda. So same picture that we saw in Burundi. So we need to do a bit more when it comes to that. So here we are just presenting to you the categorization that Africa CDC and WHO has now proposed in terms of priority countries, how we group them. In category 1, we have countries where we have sustained human-to-human transmission, and these countries actually include the DRC, Burundi, Nigeria, Cote d'Ivoire, Central African Republic, Liberia, Kenya, and Uganda. And in category 2, we have countries where we have sporadic transmission or just cluster outbreaks. We have Cameroon, Rwanda, Congo, Morocco, Ghana, South Africa, Zambia, Mauritius, Zimbabwe. And in category 3, we have countries that are bordering countries in category 1. And in category 4, we have the other countries. So we review this categorization every 6 weeks, because that's the time frame that we give ourselves to declare a country moving from active transmission to a controlled stage in terms of transmission. But one country can move to to another category, category 4 to category 3 any week. But to go down to categories with less priority there, it needs at least 6 weeks. Here, this is just a table giving us the breakdown of suspected cases that we had in the last week, the deaths among the suspected ones, but also among the confirmed ones, but also the case fatality ratio and the clades types that have been detected in countries. Now, as of AP week 43, starting from January, we also wanted to look at the distribution of cases, especially lab confirmed cases, and see what proportion is actually affecting children. So we found that 38% of all confirmed cases were found in children. So when we look at this proportion, the 38%, it's not much different to what we should have when we look at the normal distribution of the different age groups in the population. So this is normal to have close to 40% of children being under 15. But now there are variations in different countries. For example, we have in Burundi where it went to 48%, in Central African Republic it went to 50%, in Liberia it's 67%, and the DRC in general it's 35%, but in regions when they're reporting clade 1A, in endemic regions in the DRC, it goes up to 66%. And so if you use this information that I'm providing here, and you add to sometimes malnutrition or comorbidities like measles, chickenpox, it can also explain why we have a higher mortality rates among children in the DRC compared to other countries that are also reporting Mpox. So for Kenya, Rwanda, South Africa, the majority of cases that have been reported there only occurred among adults. So again, in Africa, the predominance of these infections are occurring among males, just at 53%. And I just want to bring here that for South Africa, we had a very unique transmission pattern, which involved sexual networks, especially among the males. Now, the high-risk groups that have been identified on our continent, we have the young adults, the internally displaced populations, the prison inmates, like here, where I am now, as I said, it's in the DRC in Kinshasa, an epicenter of Mpox. That is where we see now cases rising. It's in Limete, but before that, we went into a military camp called the Kankokolo. We went to visit there, and one of the problems that they're having in terms of outbreaks, it's the outbreaks that are occurring in prisons. Very difficult to do contact tracing there, and because of the superpopulation in the prison cells, you can imagine the risk and how this is progressing. So we also have mine workers and people with underlying immune deficiencies. In terms of transmission drivers, we have a close contact with infected cases that remains the most predominant mode of transmission. And here we are mentioning sexual contact and household contact. Just maybe to say a bit more about the clade 1B, clade 2 Mpox virus infection and the impact of HIV. Individuals with HIV, we know now are at a significantly higher risk of contracting Mpox. And HIV positive individuals have a high mortality rate from Mpox, evaluated at around 20%, 21% in recent data that was analyzed on the African continent. And when compared to the general population, where the mortality among HIV positive individuals is just at 9%. So the Mpox mortality in South Africa and recently among the deaths that occurred in Kenya and Uganda is definitely closely associated to HIV comorbidities, especially in cases where we have HIV that is not managed or it's just recently diagnosed. We also have high prevalence of other STIs among Mpox cases. The case fatality rates among is stands below just 10%, but as I said, close to 21% of cases that are affected with HIV plus comorbidity of, Mpox, they die. So in terms of the demographics, it's again here predominantly affecting the males in the young adults. So just quickly to give you an overview of the countries that are reporting clade 1B in terms of the epidemiology. We have here Burundi, Rwanda, Zambia, Kenya, Uganda, and Zimbabwe. And you can see that for these ones, even though I said while I was introducing on the African continent situation, I said that there is a downward trend. But when you look at just countries that are reporting clade 1B, we can see that there is an upward trend, which is now led by Uganda, followed by Burundi, where we saw an increase in the number of new cases that are reported. And just as for Burundi, they've reported so far 1,804 lab confirmed cases out of close to 3,800 suspected cases. They have not reported any related fatality, but we need to remember that 43 out of 49 districts in Burundi have reported at least one confirmed case. And in terms of laboratory performance, they're doing quite well, but they still need some support in terms of contact tracing so that we can be able to measure the what we call the conversion rates from contacts that are listed and monitored. What's the proportion of those ones who are actually turning to be positive?
Michelle, we'll need to be wrapping up a bit. So if you...
Okay. So I think here I've already mentioned something about Uganda, where we are now. So we've seen the number of new cases increasing in Uganda, but I just wanted to go quickly to the DRC. Please allow me. In Zambia and Zimbabwe, we also had the cases that have been reported, but we are happy that these cases have been contained. They were imported cases. Now, the DRC is the only country that is reporting clade 1A and clade 1B together. And we have seen a downward trend, as I said, but in terms of laboratory capacity, it's still limited. Only 8 laboratories that can perform these PCR tests on Mpox, and they are having issues in terms of a delay in confirmation of cases and also delay in transmission of line lists to the national level. So we are still following up, but we are all hoping that the number of cases are going to start decreasing, weekly. And this is just a picture to show you what I was saying in terms of the positivity rates that has started going down, but as well as the testing coverage. And on this picture, I think, again, we have maps that are just showing us what I said. There are many areas where we have high suspected cases, but they lack confirmed cases because they are not just reporting. So there is an issue to link the data from the laboratory and linking the data from surveillance or contact, the cases, the confirmed cases or the suspected cases that are coming from the surveillance lists. So I think I'm going to end, dear Chair, just with this to talk about the challenges that we have, as I said, in terms of the national laboratory coverage in the DRC, the issues in terms of diagnostic capacity, and the new picture that we see in Kinshasa, where I am for the moment in Limete, which is an epicenter with a huge number of professional sex workers. And there is serious promiscuity in this area, which is populated by close to 360,000 population. And we need really to do the best that this does not become another Sud Kivu or South Kivu, which again will lead to transmission or spread of Mpox cases to other areas. Let me stop here, dear Chair, and thank you very much for this opportunity. Over.
Thank you very much, Michelle. That was very, very informative. So again, if you have any questions, put them. There are a few questions in the chat box, but we'll deal with that when we move into the question and answer section. So now the next presentation would be Mpox risk communication and community engagement. And to help us deliver that would be Dr. Julian Anoko. Dr. Julian Anoko is the WHO Afro Team Lead for Social Sciences, Race Communication and Community Engagement for Emergency Preparedness and Response Program. And she currently leads the risk communication team in the Mpox in WHO Afro. She's a social anthropologist, has a PhD from Sorbonne University in France, and she's also trained in epidemiology, public health, gender, and health at the University Rey Juan Carlos of Spain. She has more than 20 years experience, and we hope that she would be able to give us some overview of the community response. Dr. Julian Anoko, you have 10 minutes to deliver your presentation. Thank you very much, and you're welcome.
Thank you very much, Mr. Chair. Good afternoon, everyone. Let me call you from Goma. I am currently in the Eastern DRC, supporting the response in the field. So my communication will focus on straight to community engagement, which is the main challenge that we have in the field to really engage our community, to understand the risk and act, to take the decision to apply the public health and social measures and protect themselves. Slide, please. So risk communication, community engagement, as I said before, is a decision to involve the community in acting together. Each community engagement intervention should be community-led, should be data-driven or evidence-based, should reinforce, strengthen local capacities and solutions, and be collaborative. So what we need to do is we prepare the information and the engagement strategy. We take this strategy and this intervention to the community. They take the decision and they act to protect themselves. Slide, please. So I'm going to talk about the approach of the community engagement that we have been supporting member states across the region, but also across the continent. This approach, the first thing that we do in the field and what countries are doing is to start by an advocacy to the health authorities of a health zone of an area to put in place a multi-sectoral team. And this team can also include social scientists. A multi-sectoral team means surveillance, infection prevention and control, laboratory, data analysis, logistic, OSL. So it's not only RCCE team, but it's all those teams because community is at the center of the intervention. So the second thing is we prepare an integrated engagement, as I said. So we meet with the community leaders and together we co-design and co-implement a plan. So the first thing is the co-design of the plan. We ensure that we have funds and together we map the community, including available resources and network or target or key population in the respect of the gender equity. So key population here are sex workers, we have also a transgender, we have also men having sex with men, we have all the group of LGBT, but what we have to bear in mind is that nobody should be left behind. So this is why these people are really have to be integrated in all our community engagement strategy. We develop the message together and we socialize and translate those messages in a simple English, French, Portuguese, Spanish, and in the local languages. Together, we design the type of the information, education, and communication material. This can be frequently asked questions, prevention of Mpox in school, general Mpox, sport, radio, and TV. And we conduct together a community awareness. We develop a community awareness tools. We agree on that. So the community can tell you that what we need is a sensitization or the awareness using megaphones. We can also, we want the songs. We can do the door-to-door sensitization, the cartoons, the sketch, interactive broadcast, etc. We at the central level, we have to sit with the people and they are going to really determine which tool is really able to reach the communities and able to reach the household with the information that we want to share with them. So a community team is put in place. These can be community health workers, community volunteers, but also the community leaders and women and youth and even influencers that are really influencing on the social media. So we develop together the roadmap or an agenda, and we agree on the modalities of the implementation. Further, we document the activities with photos, videos, interviews of satisfaction with all these leaders. We write together the report and we share the report with the communities. They are really proud to see how they have been engaged and how they are fighting Mpox. The last step is monitoring and evaluation and accountability. For this, we conduct some surveys, knowledge, attitudes, and practice studies to understand the behaviors and assess the communication panorama, collect the concern, counter misinformation and infodemic, and use evidence for the design of the activities. Slide, please. So this is an example of the implementation. This is in DRC, where you can see the training session on your left, and in the middle, you can also see on the right. After, these are the leaders that have been trained and the influencers, and this is at the end of the training. For this photo group session, exactly, thank you. This photo groups is at the end of the training here in DRC, and these people were the key population that was trained in North Kivu, where I am now in Goma. Slide, please. So this is another step of the implementation. As you can see, this on your left, the first picture, these are the community volunteers that are going to sensitize people far away in a village, and you can see how they are dressed. This is in Liberia. They have to walk under the rain to go and sensitize their people because they have accepted to engage their own people. And you can have a community volunteer sensitizing in the market. And on your right, upright, this is a community volunteer sensitizing into an IDP camps. As you know, here in Goma, we have more than 2,500,000 people that have been displaced due to the conflict. And we are also responding Mpox into a humanitarian crisis. So we also involve these people of the IDP camps that are coming from several places, and they are running from to save their life from the armed group. So we ensure that those people are also receive the information, and they are engaged by their own community leaders that are also IDPs. Slide, please. So this is the documentation. As you can see, we have really developed this report here in DRC on your right, upright, and this is the report of the specific engagement of key population, as I said before. And these key population have been engaged, and they are really the ones sensitizing other people into this place where sex workers are working, where LGBT and transgender are, and they engage also for the vaccination. At the beginning of this engagement, we have targeted something like 800 people, but at the end, we have vaccinated more than 1,500 people, and they're still mobilizing their own community because sex worker is mobilized sex worker, and they trust they trust their own pair instead of me going to sensitize people. This is the motor driver that they call Boda are the one here in Uganda who are really conducting this sensitization on the street to demonstrate that they are the one carrying, transporting the sick person, and they are also ready to sensitize them when they are transporting them. Thank you. And slide, please. So for the community engagement, this is the MNE. This is one excellent job, an integrated job that was done in Nigeria, and they did a survey, community listening to address the infodemic. And this is what they collected. Members of the community have raised concern about worries around Mpox. And you can see, we also ensure that we collect the community, we listen to the community, we collect their worries, and we answer to those worries. But before answering to those worries, we really quantify, as Nigeria has done here, and we see what is the biggest worry of the community. And in this case, one of their biggest worry was the sign and the symptoms of Mpox that they were not able to really understand very well, and followed by the mode of transmission and how Mpox is prevented, the issue of the vaccine, and finally the issue of the stigma. What RCC people do with that is that regarding this result, they reorient the messages and they reorient the strategy to really fit to the community concern and answer to this worry. This is the change. And we measure every 2 months, for example, we conduct another survey to make sure that the problems are changed or the problem have been resolved. Slide, please. So here you can see what was also done in DRC. And in DRC, this is the infodemic, the social listening offline and online results. I'm not going to go through all of it, but what you can see is that people are worried about the efficiency of the vaccine. They are also worried about access to the vaccine and the side effects after vaccination and the religious issues and theory of complots. I just want to focus on the access to the vaccine. As Dr. Michel said, we have many sex workers that are infected, but also we have children under 18. And up to now, the vaccine that we receive, the current campaign is not, we are not vaccinating children because the vaccine, the children that not been, the investigation that not been conducted to know what are the side effects on children. So many families are coming with their children and they want to vaccinate them, but the protocol is not allowing giving the vaccine to the children up to now. This is why you can see that this is one of the issue, the concern that the communities are raising. We have also the religious issues. In many religions, you know, this many Christian church, they don't allow their fellow people to be vaccinated. And so many people are saying, I'm a Christian, I'm in this church, but my shepherd or my pastor or my priest didn't allow me to take the vaccine. How can I do? But I'm infected by Mpox, or my wife is infected by Mpox. So we respond to this with a lot of strategies. We go back to the field, we discuss with people, we see how they can really take the vaccine and understand that the vaccine can be safe, or they can also respect public health and social measures, although their religion is not allowing them to do so. And we really explain to them how it is important to save your body if you want to be a good Christian or be safe. You know, you have to be safe if you want to continue to practice your religion. So we discuss all this with the priest. We don't take the decision on our side. We discuss with the imam of the Muslims, with the priest of the churches, and they give us some talking points to transform this talking point into messages that we share with the people. Slide, please.
Yeah, so Dr. Julian, you should be rounding up now. Yes.
Yes, please. Slide again, please. So these are really the lesson learned. This is my last slide. And what we have seen across all these Mpox responses, that community engagement is key to build and maintain trust. It prevents resistance. It helps us also to counter misinformation, rumors, and infodemics by providing information that respond to the concern and worries. Empower communities for emergency preparedness and readiness. You can do it through a community engagement, and this is what we are doing. Although we have this lesson learned, we have also a lot of challenges. The main challenge is the insufficient allocation for funds to implement RCC plans in general and to engage communities in particular at the early stage of the declaration of the outbreak in any country. the insufficient dominion of community engagement approach from stakeholders, and also the unwillingness of stakeholders to engage with community, because they say that this is a long process. You have to go with them, sit with them. And also people argue that result of community engagement not always meet the expectation of the donor, because these results are mainly, the approach is mainly qualitative before you have this quantitative data to share with your donor. So I think that this is my last slide. Slide, please. So thank you very much. Asante sana. Merci beaucoup. Muchas gracias. Mucho obrigada. Thank you.
Okay. All right. So, Dr. Julian, thank you very much. And please, Dr. Julian, go to the Q&A session. There are a few questions for you there. Michelle, also there are some questions for you on the Q&A. So let's see, so that we can answer as many questions as possible for our participants. Now, let's move on to the next presentation that looks at Mpox and HIV interaction. This will be delivered by Dr. Agnes Shetty. Dr. Agnes Shetty is the physician with an MSc in maternal and child health. She joined WHO in 2023 as the medical officer in the Office of HIV, PNTCT, and STI, working with the HIV, tuberculosis, and hepatitis team, which is part of the universal health coverage, communicable and non-communicable disease cluster within the WHO regional office. Dr. Agnes, you are welcome, and then your audience are ready for you. Thank you.
Thank you. Thank you. Good afternoon. Good morning, everyone. As the presenter said, I'm Dr. Agnes Shetty from WHO AFRO, and my presentation is on Mpox and HIV interactions. As you know, there are many interactions and intersections between Mpox and HIV. There are common at-risk and vulnerable populations like sex workers, men who have sex with men, pregnant women, and you've heard about this from two previous speakers. There are some shared transmission routes through sex, mother-to-child transmission. People with advanced HIV are at risk of severe Mpox, and there are some population groups with Mpox who may suffer stigma and discrimination, just like persons living with HIV have suffered from stigma and discrimination. And we know that stigma can undermine public health efforts. So linking Mpox services and HIV programs can ensure that health needs of vulnerable population are met more effectively, can enhance the overall response to both diseases, and can help improve public health outcomes. Now, I have two slides on transmission of Mpox because we often have questions about this. So as you know, Mpox spreads from person to person through close contact. And when we say close contact, we mean skin to skin, mouth to mouth, mouth to skin, prolonged face-to-face with somebody who has Mpox. And we know, and as you've heard already, people with multiple sexual partners are at high risk of acquiring Mpox. But Mpox can also be transmitted during pregnancy or birth. And people can also contract Mpox from contaminated objects. And there is also animal to human transmission that can occur from infected animals to humans. Now, drivers of Mpox transmission differ in different contexts and with different clades of Mpox, and transmission dynamics evolve over time. So I borrowed this slide from Rosamond Lois from WHO headquarters and shows potential transmission dynamics in Kamituga, a gold mining town in eastern DRC. And as you can see, it can start in sexual networks outside the household. Then transmission goes into the household to different people, including children, and then again outside the household, and again inside the household, and so on as time evolves. I think what is good to mention is that there is much we still need to learn about what drives transmission and how this virus behaves. Now, if we come to key messages, Mpox and HIV, we know that people living with HIV who are on viral suppression, those who are on treatment and are virally suppressed, have the same prognosis. There is no data to suggest that severe Mpox is more common if ART is effective. However, we do know that people living with HIV...
Hello, Dr. Agnes. it looks like your slides are not moving. The Secretariat, can we help? The slides are not moving, yeah.
I'm on slide number 5 now. Which slide are you seeing?
Oh, it's off now. I'm sure the Secretariat would work on it, yeah.
Do you want me to stop sharing and you share
No,
the
I think the
slide?
Secretariat is doing that. I think we would. So you are now on slide number
5. How many
Number
slides have
5.
you seen? How many
Yes.
slides have you seen so far?
Yes, we've seen a few. Let me see.
I'm on slide number 5 of 14.
Yeah. Please go. No, that's not. You've gone too far. Please stop them.
Okay. Okay. Let me talk about this slide again.
Okay.
If you didn't
All right.
before.
All right.
So this slide is a slide that I borrowed from Rosamund Lewis from WHO headquarters, and it shows drivers of Mpox transmission. And we know that the drivers of Mpox transmission differ in different contexts and with different clades, and that transmission dynamics evolve over time. And as you can see from this slide, it can start in sexual networks, then go into households where different people are infected, including children. And then the dynamics is outside the household and again inside the household. And I think the important message is that we still need to learn a lot about transmission dynamics and about how this virus behaves. Next slide, please. So if we come to interactions, Mpox and HIV, biologically, it doesn't seem that people living with HIV have higher risk of contracting Mpox. But sometimes because of overlapping networks and overlapping risk factors, we find that we have more Mpox in people living with HIV. People on ART, on HIV treatment, and who are virally suppressed have the same prognosis. There is no data to suggest that severe Mpox is more common if ART, HIV treatment, is more effective. However, we do know that people living with HIV have higher risk of severe Mpox disease and mortality in case of immunosuppression. And immunosuppression in people living with HIV, this is people with advanced HIV disease, those who present late, and those who have low CD4 count. And people undiagnosed prior to a diagnosis of Mpox have elevated risk of death if they develop severe Mpox. And how severe Mpox presents? It presents with larger, more widespread lesions, and we can have lesions in the mouth, eyes, and genitalia. Can present also with conditions such as inflammation of the heart, brain, or other organs, with secondary bacterial infection of skin, blood, and with lung infection. Next slide, please. Now, WHO recommends that we test for HIV and other sexually transmitted infections when we test for Mpox. We know that primary and secondary syphilis can sometimes present similarly to Mpox, so syphilis is an important differential diagnosis. We also have reports of high rates of other STIs in the clade 2 Mpox outbreak. So we need to test for HIV and test also for other sexually transmitted infections. When it comes to HIV treatment, people living with HIV who are on treatment should continue their treatment as before. And programs must ensure that people living with HIV remain in care and on effective treatment. And for people who were not on treatment when diagnosed, either because they were never on treatment or maybe because they were on treatment and they disengaged from care, we should reinitiate treatment for these people and ensure that they get adherent support and they remain on treatment. When it comes to Mpox and pre-exposure prophylaxis, in the Africa region, a lot of people are on pre-exposure prophylaxis to prevent acquisition of HIV. The message is pre-exposure prophylaxis medication remain effective, and people who are on PrEP should not stop PrEP, even though they are exposed or if they are infected with Mpox. Next slide, please. Now, WHO recommends that that program promote integration of HIV and syphilis testing within the Mpox response. And to do that, WHO has developed a standard operating procedure to promote integration of HIV syphilis testing as part of the response. This promotes an integrated testing approach, and during a single client contact or visit, when a person presents for testing for Mpox, as well as for ongoing HIV and syphilis testing. For each individual tested for Mpox with suspected or probable Mpox, additional testing can be done for HIV and syphilis. What do we expect from this integrated testing? We expect to identify individuals with Mpox infection and undetected HIV and syphilis infections. We want to identify individuals with Mpox infection and high ongoing risk that can benefit from HIV prevention. We want to perform additional laboratory tests, viral loads, CD4 for newly diagnosed HIV patients, and eventually establish a treatment plan for patients diagnosed with Mpox and/or HIV and syphilis. Next slide, please. So we have well-established HIV programs in all the countries in the region, and this provides us with many opportunities to leverage infrastructure, resources, expertise, and community engagement strategies to support the Mpox response. HIV programs can help to disseminate information on prevention for at-risk and vulnerable populations, and WHO has guidance for MSM and sex workers, can support early detection of Mpox, can support clinical management of people living with HIV infected with Mpox, can ensure that people living with HIV are diagnosed, started on treatment, and remain on effective treatment, can use their expertise to engage the community in the Mpox response, and we heard from the previous speaker on community engagement, and can use HIV experience to address Mpox-related stigma and discrimination. Next slide, please. The WHO HIV programs at headquarters and in the region has brought together an informal community reference group at the global level, and is also supporting the co-creation of national and subnational community reference groups. These reference groups include community leaders, community experts, community academics. And the community reference group advice will inform WHO's strategic response to the Mpox response. Especially, it will advise WHO on communication tools and approaches that can be most effective, on community sensitivities, on how the community can support the prevention, early detection, and reporting, and can also ensure that the lived experiences of those affected by Mpox are heard. And as you know, and it's been repeated by everybody, community engagement is a cornerstone for effective Mpox response and can ensure that public health efforts are relevant, trusted, and supported at community level. Next slide, please. Next slide, please. And I just want to end with this slide. There are several WHO publications that support efforts to integrate HIV and Mpox responses. There's publication on risk communication, public health advice for sex worker on Mpox, public health advice on Mpox for men having sex with men. And at this website, you can get a lot more information. And WHO continues to develop new guidance and update existing ones to support Mpox and HIV integration. Next slide. I thank you for your attention. I acknowledge Dr. Peters from headquarters, from whom I borrowed a few slides. Thank you.
Thank you very much, Dr. Agnes. Looking at how leveraging the experiences from HIV programs to support Mpox. So look, and she's nicely described some of the interactions between HIV and Mpox. Thank you very much. So Dr. Agnes, kindly be monitoring the question and answer chat box so that in case there are any questions for you, you can respond for us. Now we'll move on to country experience. And we have the pleasure of having Dr. Emily Tumoranchire, who is currently the principal medical officer at the Ministry of Health in Uganda. She has a Bachelor of Medicine and Bachelor of Surgery degree from the Makerere University and a Master of Medicine in Family Medicine from the Mbarara University of Science and Technology. She also has a Master of Public Health from the University of Liverpool, and then she's also completed some additional training in the University of Washington. As a principal medical officer, she's the focal point for community engagement and then the social protection pillar at the Ministry of Health in Uganda. Dr. Tumoranchire plays a vital role in shaping policies and programs to address the needs of the community. Colleagues, join me to welcome Dr. Emily Tumoranchire. Dr. Emily, you're welcome.
Thank you very much for that introduction. I think I will not again introduce myself because everything has been said. So I think I'll start off with my presentation. So I'll be presenting our experiences in Uganda in managing the Mpox generally, not only the community component. So I think I'll start sharing my slides. Yes, thank you very much. So I am here to take you through the country experiences for Uganda. So as you can see, there is a map briefly of Uganda for those who might not be having a clear picture. And as like our first case was reported on 24th of July, 2024, that was in Kasese district. As you can see it there, it is red at bordering DRC Congo. And since then, we've so far recorded 468 cases across 38 districts, with 34 districts still having active transmissions. And most of our cases, we've noticed they are related to community transmission, and we've not yet had any facility spread infection. And as I've already told you, it's majorly through sexual intercourse and close body contact that spread. And the presentations, they have given them to you, which are more or less the same, like for us in Uganda. And for us in Uganda, the most affected people are the school children, fishing communities, and commercial sex workers. And as you can see on our map here, there is Nakasongola, which is up here. You can see the word. It's one of the fishing communities that is accounting for most of the cases, like approximately 13%. And also Uganda, whether Kampala here together with Wakiso are the capital cities now currently accounting for most of the cases that we are having in Uganda. So who are our stakeholders in this response? In this response, of course, the government of Uganda is one of our biggest stakeholders, where we include the Ministry of Health, Ministry of Education and Sports. As I've told you, the children are majorly affected, so we have to work with the Ministry of Education to ensure that the school transmission is well controlled. We have Ministry of Defense, so we have the prison services, the district local governments, because the transmission is happening in the community, so you have to work with the district local governments. We have, of course, health partners in the country like WHO, CDC, Baylor, USAID, among others. And we also have community-based organizations, community groups, and of course, local leaders. So currently we are utilizing the systems that are already in place, and they've really helped us in managing this response. For example, these systems are in place when we're managing Ebola and also when we're managing COVID. So we just reactivated them. For example, the National Task Force and the District Task Force, and they're helping in controlling the response. And also we've been utilizing the existing, for example, HIV services that are around, for example, like the sample transportation system, where the country has approximately like 140 hubs that have a transportation mechanism of transporting the samples from the community to the central lab, especially like for PCR. So at the moment, we're utilizing that mechanism to transport samples from the community to the central labs for testing. And of course, we are utilizing the HIV services to ensure that all patients who are HIV positive who come for their drug refills and routine reviews, they are also tested for Mpox. And even those ones who are tested for Mpox, we ensure they are tested for HIV so that appropriate treatment is given to these patients. So in this response, we have a number of pillars. So I'll briefly talk about the different pillars and the work they are doing in managing this response. So we have one for coordination. And so far what is working well is that when Mpox had already started, when it started in DRC, as a country, we started putting in place a national preparedness and response plan, keeping it ready for utilization in case we need to. So that was very good. It helped us because we don't have to start from scratch after getting our first initial case. The National Task Force and the Incident Management System at the Ministry of Health were activated, and they are currently doing all the coordination in this response, which is good. We already had some staff dedicated to, like, for example, the Incident Management System. So it was quick for us to get into action because we already had people who knew what is supposed to be done. And we also activated district task forces, for example, the categorized high-risk districts that were mapped out at the beginning to ensure that when a case comes up, they're able to swing into action, and also they're able to start on the sensitization of the community so that we can even be more vigilant and quickly identify any case, especially in the high-risk districts, where initially we had mapped out all those districts that are bordering DRC. And of course, weekly meetings to update ourselves on what is the situation on ground and any other new things that we need to do. So in this coordination, of course, things have not been smooth, as we all know. So there are some lessons we've learned that are helping us going forward. For example, we need regular review and update of our preparedness and response plan as per the evolvement of the epidemic, because at the beginning you have a different idea of how this epidemic is going to go, but then it surprises you. Like for us, we were surprised. Initially, we thought it would be something small, but the numbers are growing every other day, as they earlier on presented. And then there's also need to develop a response plan for different levels of the outbreak in advance. So that in case now we say now we need to up our gears. We just get one of the already drafted ones. We do a little drafting, a little adjustment here and there, and then we swing into action. And of course, the existing systems, there is the response management, and we have a challenge of network, like a network coverage across the country, where sometimes we'd have to use internet to communicate with the healthcare workers, to communicate with the people down on the ground in the communities. So sometimes it would be very challenging, but we are trying to adjust. If it means going up like a tree or a mountain, we do that and we get the network. So surveillance, what we did at the beginning of the response, we did capacity enhancement via online and physical platforms for health workers. That was to increase their vigilance. And we also enhance surveillance capacity at the points of entry, because we're anticipating that Mpox will be brought in through our points of entry. And we did our risk mapping to ensure that we heighten our vigilance in those high-risk groups, whether high-risk areas. And of course, there was already an existing reporting system in place that also is the work. And the lessons learned under this pillar is that it's very key to utilize collected data for planning and decision-making. For example, initially, we anticipated cases to arise from the districts bordering DRC, but then after one case from that district bordering DRC, we were surprised when our next cases were coming from the center of the country. So we had to get back onto the drawing board and recategorize our risk. We do our risk mapping afresh so that we're able to plan better for the population. Then there has to be flexibility, because this response, things will not turn out exactly the way you anticipated them, because initially we enhanced the surveillance capacity at the points of entry, but now this time we realized we need to enhance the capacity of all the the route charts of the long distance truck drivers, because we realized that one of the key people who are transmitting the Mpox in the country. And of course, replanning and strategizing is very key when things are not happening as predicted. So when you go to the laboratory, immediately when we reported the case, that our 2 national testing laboratories were activated to start testing Mpox, that is UVRI and CPHL. We also conducted virtual training for lab staff on sample collection, packaging, and transportation, and deployment of a mobile lab to Kasese when we reported an index case, because at that point we anticipated more cases from Kasese district since it is bordering DRC, and of course utilization of the existing lab transportation system that is already being utilized by the HIV team. So for the lab, we've realized that there is need to deploy more mobile labs to reduce the turnaround time, because the turnaround time is dependent on when the sample gets to Kampala for testing. And if we could deploy more mobile labs to the hotspot areas, would reduce the turnaround time and we're able to act more swiftly. There's need for more resources, especially the personnel and the reagents, because the people who are doing the Mpox testing have to work overtime to cover up for the gap. And there's need for quick validation of more testing platforms to ease the testing processes. And of course, budgets need to cater for emergency transfer of samples, because the use of the routine available sample transportation is causing a lot of turnaround time that is actually affecting the response management. Then the care and treatment. Of course, we did physical and virtual trainings of all healthcare workers to orient them on what is Mpox, because this was relatively new to the healthcare workers in Uganda, and how to manage it and how to screen patients for Mpox. And we did deployment of the emergency medical teams to support the heavily affected districts. For example, like in Nakasongola, we were getting very many cases, but their health system was not big enough to handle the very many cases they are having, in addition to attending to the normal health needs of the community. Of course, community of practice webinars to ensure healthcare workers are routinely they are routinely sensitized about what Mpox, what is new, what is happening, and how can we manage it better. And these webinars are attended also by specialists who have their input and were able to learn how to handle these patients better. And of course, the treatment guidelines were developed. Then we realized there is need to open more treatment units very fast, because the numbers are increasing at a very fast rate. And the one in Kampala, where they're treating most of the people, is getting overwhelmed. Then there's need for planning for high volume of patients in the capital city. Kampala is now the hotspot, and we anticipate the patients are going to continue increasing by virtue of the fact that it's the capital city. And then there's need to plan for feeding. We've had scenarios where the patients under isolation and treatment, they've escaped because they are not getting food. And most of our funders, they are not catering for the point of food, which is something that is very important, because you cannot keep someone in an isolation treatment unit without adequately feeding them. They'll start thinking of the food they've left at home, and before you know it, they've escaped and even failed to trace them, and then they'll continue spreading the disease. And of course, we realize there is more need to follow up the patients post-discharge, because we are still learning more about Mpox. Then there's community engagement pillar and also risk communication pillar. So at the start of when we reported the case, we had an anthropology study done in Nakasongola, which was at that point the hotspot area. And we are able to gather important information to give us more insight into the mode of transmission and how can we actually educate the communities better to be able to control that transmission within those communities. And of course, we identified the high-risk communities, and we started community engagements with these high-risk communities through their leaders and community-based organizations. We activated the parish and village health task forces to ensure we have a community-led response. And we had deployment of film vans to run health education messages in busy centers, especially in the high-risk districts and those hotspot districts. And we put up Mpox educational materials at points of entries, facilities, and schools to ensure at least people are continually reminded about Mpox. So our lessons we are learning is that the population still has a low risk perception of how very bad this disease is and how dangerous it is, because they are seeing people are not dying. They are relating it to the normal skin conditions they've been having, like scabies and chicken pox. So their perception is still low. Their risk perception rather is still very low, and it's affecting the behaviors of the community. And of course, realize we need more anthropological studies to be done in other districts with rising cases, because there's the different districts, people in different districts behave differently. And of course, even your interventions in terms of health education and in engaging them will have to be different by virtue of the fact that we are very different. And then community entry strategy should be tailored to the community, and they should be culturally appropriate and sensitive, because how you try to enter a community will determine how the uptake of what you're trying to tell them. So it's very important. And also in Uganda, we have diverse languages. And this makes it very difficult because we have over 70 languages spoken in the country, and all these education materials have to be translated to all these languages to ensure that people are reached. So what are our next steps? Our next steps, we are currently in the conclusion of updating our national preparedness and response plan so that we meet the current demands. And we are also activating all district task forces at all levels, that is at the district, at the parish level, and at the community level, because now we are planning for the scenario of the whole country has an Mpox case. And also we are setting aside isolation and treatment space at all district hospitals and health center force to be able to manage the patients that will come in. And we are preparing all regional referral hospitals to handle the Mpox testing. The labs are being supported to be able to do this testing so that the samples don't have to be taken all the way to Kampala, hence creating a long turnaround time. And they are functionalizing the isolation treatment unit at the National Referral Hospital, because we are taking most of the patients in Entebbe. The Entebbe Regional Referral Hospital is now currently overwhelmed. So we are realizing the need to functionalize the one at the National Referral Hospital to be able to meet the rising demand in Kampala Metropolitan. And also all hospitals in Kampala and Wakiso are being supported to set up at least a small isolation and treatment unit to be able to handle the numbers. And vaccinations, we are also anticipating to start vaccination like early next year in January, and we shall start off with the high-risk categories, that is our frontline health workers, commercial sex workers, long-distance truck drivers. And at the moment, we are starting now to create vaccine demand so that when the vaccines are available to us in the country, which we anticipate by January next year, that people are able to take up the vaccination, and we avoid wastage of the vaccines because the community is not taking them up as anticipated. And also at the moment, additionally, we are now looking into starting also home-based care, and we've developed the guidelines. They are in place. And because the numbers are now overwhelming, so we are thinking it's better if those cases with mild illness, they are managed at home, and the community members and the home members are oriented very well on how to take care of the patient and how the patient can take care of themselves without further spreading the disease. So that's what I briefly had regarding what is happening in Uganda. Thank you very much, Chair.
Thank you very much, Dr. Emily. This is truly experience from the field. And I think the lessons that you have learned in Uganda, hopefully some of us will be able to put those to work in where we come from. So for the next presentation, we'll be looking at vaccine equity. And we have the privilege of having Dr. Vilaheliu, who is a public health physician with experience in immunization, research and delivery. She's a technical officer in immunization and currently supports the Mpox emergency response at WHO AFRO. Previously, she worked with the PAHO in DC, Washington, DC, and also WHO Western Pacific Regional Office with a focus on live course immunization and also at Gavi. So colleagues, join me to welcome Dr. Alba, who would discuss vaccine equity issues. Dr. Alba, you're welcome.
My chair, it's a pleasure to be here today just to present about Mpox vaccination and equity. So as soon as I can see the slides, I'm going to start the presentation. I think they are coming. Thank you so much. We have been hearing a lot about Mpox, and one of the tools that we have is Mpox vaccines. So what I'm going to focus the presentation today, it's about trying to define what are the vaccines that are available, what are the recommendations that have been provided by strategic advisory groups on immunization, as well as what is the immunization strategy in this case. Next. Let me recap, because we have been hearing a lot about Mpox today, and we had really interesting presentations. But I just want to say that we know that clade 1, more often the cases lead to more severe disease and death, while clade 2 usually is a self-limiting and most people recover within a few weeks. But having said that, regardless of the Mpox clade, we know that there are certain populations that there are higher risk of severe disease and complications. When I say complications, I mean secondary infections. It could be sepsis, it could be pneumonia, it could be encephalitis. And we know that the groups are specifically young children, pregnant women, as well as people with immunocompromising conditions. That means, and also includes persons that are untreated or uncontrolled with uncontrolled advanced HIV infection. This has implications also in terms of the Mpox vaccine recommendations. Next. So as our colleague already presented, Dr. Muteba Michel, about what are we seeing on the epidemiology in the African countries, I want to highlight here the high burden among children under 15. I'm not going to go in detail because he already described this slide, but I want to highlight again to say that 38% of all cases, confirmed cases that have been reported, are in children that have less than 15 years of age. Also, I want to highlight the impact of comorbidities, because Mpox mortality in South Africa and recently in Kenya and Uganda has been closely associated with HIV comorbidities, especially in cases where HIV is unmanaged or recently diagnosed. So I want to highlight these 2 points because I'm going to be talking about recommendations for infants and children, pregnant women, as well as those that are immunocompromised. Next. So recently, in August 2024, the WHO Strategic Advisory Group of Experts on Immunization, from now on in the presentation, I'm going to refer to it as SAGE, provided recommendations for the use of Mpox vaccines. And there are 2 specific situations where Mpox vaccines are recommended. The first one, the one that you see on the left side of this slide, is in the situation of an Mpox outbreak response, which is the case that we are considering right now in the African region. And then the second situation, it's for primary preventive use outside an outbreak. And in this case, the recommendation is mainly recommended for laboratory personnel working with orthopoxviruses, which is the virus that causes Mpox. So let me focus then on the box on the left side of this slide, because this is what we're considering here in this region. So vaccination is recommended for persons at high risk of exposure to Mpox in an outbreak. And there are 4 groups that we are considering. The first one, based on local epidemiology, the members of a geographically defined area or a community, it could be a village, including children, that's really important, with a documented high risk of exposure to Mpox. That's one. The second group, and we have been hearing also about it today, it's sex workers, gay, bisexual, or other men who have sex with men with multiple sexual partners, or other individuals with multiple casual sexual partners. The third group are those that are in the front line. Either it could be healthcare workers at risk of repeated exposure because they are seeing cases, or suspected cases, clinical laboratory and healthcare personnel performing diagnostic testing for Mpox or providing care, and also those that are outbreak response team members. And finally, the fourth group is the contacts, people who have been in contact with a person with Mpox. And the vaccination in this case is recommended with the aim to decrease the chances that that person is going to develop Mpox, ideally within 4 days of the first exposure. So those contacts may include children. It could include also other people in the household, or also people who are in congregate settings, as it could be prisons, school, health facilities, or residential facilities. So in a nutshell, what I'm trying to say is that there are two situations where we can vaccinate against Mpox. It could be post-exposure, so a person who has been exposed to someone who has Mpox, or could be also pre-exposure in groups that we know that they are higher risk of presenting more severe disease. I want to contextualize these recommendations in the context of the Mpox Global Strategic Preparedness and Response Plan, as well as, more importantly, the Mpox Continental Plan for Africa. And in these cases, what these plans define, it's what should be the vaccination strategy divided by different phases. And for the first phase, there is agreement between the plans to focus as a first priority of those that have been in contact with cases. That could include children, could include people in the household, could include other people who have been in contact. And also those that are at front line, it could be healthcare workers or frontline care workers. Countries also might consider other at-risk populations based on their local epidemiology. And then as more vaccine supply becomes available, other phases of the vaccination might be coming in the future. But right now we are just really focusing and targeting those that are higher risk of exposure. Next. And how many vaccines do we have right now? So there are 3 vaccines that have been licensed for use against Mpox. And of these vaccines, these vaccines are developed using the same virus, the vaccinia virus, that was used for smallpox vaccines. So when we say first generation, second generation, third generation of Mpox or smallpox vaccine, what does it mean? So it means that the first generation were those vaccines that were used for the eradication of smallpox. And right now, the ones that we have available in the market, there are second generation vaccines and third generation vaccines. Why the difference between first and third generation is important is because those that are third generation, they have an enhanced safety profile because the virus has been more attenuated. So it means that second generation ones, viruses still have replicating capacity. So it means that when you get a vaccine, and this is a vaccine, the third one that you can see on the right of my slide, when you get vaccine, it has a capacity to replicate in the cells of where it is administered, and then provides what it does. It doesn't take. What it means that it's kind of a scar after vaccination. This is the case for the vaccine that we call ECAM 2000. It's a second generation one. It's the one that you can see on the right side of my slide. And as I said, it's a replicating vaccine. LC16, which is the one in the middle, is a third generation one. So it means the virus has been more attenuated, but it's a minimal replicating vaccine. So also still has a capacity to replicate in human cells. And that's why also when administered can produce the tape, the scar of vaccination. And finally, the one on the left, it's the modified vaccinia type of a scar because it doesn't have the capacity, the virus, to replicate in mammal cells or human cells. So it doesn't have the capacity to produce infection in the person that has been vaccinated, neither for that person to transmit it to others. And that's important because then it is going to have implications on who can get that vaccine. And there are 3 brand names of this vaccine. And it's exactly the same vaccine because all is produced in Denmark, in the same manufacturing capacity, but under 3 names. The first name is Genius. This is used in the US. Imbamune, which is used in Canada, and then Imbanex, which is mainly used in the European Union and UK. And that vaccine has been recently pre-qualified by WHO for the use from 12 years of age. The rest of the vaccines haven't yet, they don't have yet the EUL from WHO, neither the pre-qualification. So for the rest of the presentation, I'm going to mostly focus on the first vaccine, the one that you can see on the left, because it's the only vaccine that right now it's available in African countries. And for the countries that have started already vaccination, it's the only one that is being used. Next. So as I said, depending on what type of vaccine, we have to consider which groups can get that vaccine. So if we consider MVA-BN, the one on the left, so it could be used for immunocompetent adults, non-pregnant, and this is also the case for other vaccines like LC16 and ACAM2000. But then when we look at the special groups, as you can see in the slide, there are certain groups that other vaccines are contraindicated. The only one that could be used, sometimes on label, sometimes off label, in all groups is MVA-BN. And I'm not going to say anything now about infants and children because I'm going to talk more about it later in the slides. But I want to highlight that adolescents, they can get the 3 vaccines. Pregnant and breastfeeding women, only there is one vaccine that could be used on them, which is MVA-BN. And this says off-label. What's the meaning of off-label? That means that there is a difference between what the regulatory authority in terms of the insert of the vaccine says versus what are the global or national policy recommendations. It could be the NITEC, the National Immunization Technical Advisory Group. So it's based on the country to decide if they would like to proceed on an off-label basis. And then for immunocompromised, there is only one vaccine also that can be used, that is MVA-BN. Next. For children and infants, and this is important because as we said earlier, 38% of the cases in the African countries are in children under 15. So for infants of children, where consideration is given to vaccination, a non-replicating MVA-BN vaccine or a minimally replicating LC16 vaccines might be used. Again, I repeat that for now, we only have one vaccine available, which is MVA-BN. Replicating vaccines such as ACAM2000 should not be used in infants, so it means children under 1 year of age. I want to highlight also that, as I said earlier, while MVA-BN is currently not licensed for using under 12 years of age, it might be used off-label, and these are the WHO SAGE recommendations in infants and children as per WHO SAGE and national recommendations are relevant. This means that MVA-BN vaccine use is recommended by WHO SAGE for all persons, including infants and children, at risk of exposure to Mpox in at-work settings, when the benefits of vaccination outweigh the risk. And what's the data that it's based on what SAGE decided to make this recommendation of label? So we have data on the use of MVA-BN in children from studies in 159 children, as well as in additional 1,000 children. And no adverse events or serious adverse events were observed. Also, we know that the same virus vector was used in the Ebola virus vaccine, and then good safety profile was shown when it was administered to more than 50,000 children. So based on that, that's why WHO SAGE made those recommendations. Next. I want to highlight also countries in the different regions of the world are using MVA vaccine in children, as it is the case in the United Kingdom, Canada, United States, in the case that they have been contacts of cases. So it means that it's post-exposure. You can see more details, and I guess that these slides are going to be distributed. Next. And this is my last slide because I want to provide an overview about what has been happening, what's the situation in the region. As I said, we only have one vaccine available, which is MVA-BN vaccine, which is a non-replicating vaccine that could be used in infants, children, pregnant women, immunocompromised. So today, Nigeria has received 10,000 doses. And then there are other countries that have already started vaccinating against Mpox. It's the case of Rwanda, who has received around 5,000 doses, and vaccination has started by the end of September. And also DRC, who has received already 260,000 doses. The vaccination was started around a month ago, and more than 50,000 doses have already been administered. So a lot of lessons are coming from DRC. Looking forward, I want to say that WHO and Africa CDC have already allocated through the mechanism of a mechanism that it's known as Access and Allocation Mechanism, AAM, almost 1 million doses, so nearly 900,000 doses to 9 African countries. And the 9 African countries are Central African Republic, Cote d'Ivoire, the DRC, Kenya, Liberia, Nigeria, Rwanda, South Africa, and Uganda. Well, the largest number of doses has been allocated 85% to DRC because it's where most of the cases are. It's also important to mention that last week we met here in Brazzaville with 17 countries because the first step in order to be able to be successful on vaccination against Mpox is having a good, strong plan. So we met here with the 17 countries and they continued developing their national plans with the aim to really identify what's going to be their vaccination strategy, how they're going to target the different groups, and how they're going to make this vaccination successful in a way that vaccination really targets those that are at higher risk. Thank you so much.
Thank you very much, Dr. Alba. So now we can start the question and answer segment. But meanwhile, the presenter, please have a look at the Q&A and there may be some questions for you. But I'll take a few of them. Maybe I'll take about 2 or 3 at a go, and then the presenters would respond. The first one has to do with, and it's coming from Fatia. She's asking how can she get a validated Mpox management protocol and also some of the diagnostics tools available. So probably this one will have to be answered by Michelle or Agnes. Then there was a question from Walter, who mentioned about asymptomatic and symptomatic cases and how it shapes the dynamics of transmission. So that one again, Michael and Agnes, Michelle and Agnes, you can help us with that. Then there's one question from Yoruba that was saying that many cases are children 0 to 60 months. Are you seeing more nutrition as a comorbidity? So I think again that one will be Agnes and Michelle. Can you kindly try and answer these, and then I can bring you on the next set of questions? Agnes? Yes, okay.
Hi, this is Agnes. So I'll answer the question on asymptomatic transmission. So although getting Mpox from somebody who is asymptomatic, that is not showing symptoms, has been reported, information is still limited on how common this is. And this is in the WHO document 101 on questions and answers about Mpox. So there has been reports that somebody who's asymptomatic, somebody catching it from somebody asymptomatic, but there is no information on how important and common this is. Thank you.
Michelle? And then again, Agnes, since you are on, there was this question on the risk of contracting Mpox among persons living with HIV. I think in Michelle's presentation, he said there was basically the risk was not increased for persons living with HIV. And then you said there is kind of like the risk is increased. But of course, we all agree that people who are immunocompromised have the disease severity and then possibility of mortality is higher. Can you clarify that regarding PLHIV and the risk of contracting the infection?
Thank you. So in my slide, I showed how Mpox is transmitted. So this question of whether people living with HIV are at more risk of contracting, this is one question. And it's very different from the fact that somebody living with HIV and with immunosuppression is at risk of severe Mpox disease and of dying. So this is one fact. Somebody living with HIV, with immunosuppression, meaning with advanced HIV disease, low CD4, etc., the risk is for severe Mpox disease and of dying. Now, whether somebody who has HIV and is on effective treatment, whether this person is at more risk of contracting the disease, this has been discussed with experts in headquarters. And the answer is people living with HIV were overrepresented in the clade 2 outbreak. So there was a higher proportion of people living with HIV than people from the general population. And similarly, when looking at WHO data, relatively high proportion of people living with HIV in the cases reported. However, this is from experts from headquarters. Biologically, there is no increased risk for somebody living with HIV of contracting Mpox. Biologically, there is no increased risk. When we see more people living with HIV, this is because of networks, because of common modes of transmission through sex, and then common at-risk and vulnerable groups like sex workers and MSM. Thank you.
All right, thank you very much. So I think I'll pick 3 more questions and then we'll draw the curtains. This one goes to Dr. Julian. They say, how do you assess community preparedness? Is there any tool that civil society organizations can use? And then also there's a question from Luemba that's asking, what are the main systems used to confirm Mpox? That is the test used. Is a gene expert platform for PCR tests? Can that be used? And there's also a question to Dr. Emily from Franco, who works for a CSO, is asking how can my organization help in the sensitization about risk of Mpox? Franco is in the Busaga region in Uganda. So Emily, and then whoever can take on the diagnostic test, and then Dr. Julian.
Thank you very much, Professor. This is Dr. Julien. Yes, for the question regarding how to assess community preparedness, if there is a tool, WHO has a tool which is called readiness, assessing readiness. It is a tool that we use. It has 7 to 8 components, and we have one component which is the community risk communication and community engagement assessment. I can share the link here in the chat. And this tool also, I think it can be found online. Let me just check and share the link here in the chat for the person who asked the question. Thank you very much.
Okay. Dr. Emily.
Thank you very much, Prof. I've seen the question from Franco Wambi. I think okay, I have seen the question from Franco Wambi, so I think I will get in touch with him and then we see how we can work together on increasing the sensitization of the people in his region to help in the sensitization and prevention of Mpox. So Franco, I'll get in touch with you. I think I wrote down your number during the introduction. You put it in the chat, so I'll get in touch with you and then we'll see how we can plan a way forward to help the communities that we serve. Thank you very much.
All right, so thank you very much. So I'll do a quick summary. I think this has been very, very, very interesting. I really want to thank the presenters. So we actually went through the epidemiology and transmission of Mpox, and the case was made that we have cases increasing in Africa compared to the rest of the world, and then they also outlined the at-risk populations, like men who have sex with men, and then also transmission through close contact, including sexual contact. We've also seen cases going down in DRC, but I think Uganda's cases are still climbing. And it was also stated that 38%, nearly 40% of all cases are among children. Then also, we learned that community engagement and monitoring and evaluation is critical to the success of the response. This builds trust, it counters misinformation, and prepares the community for the response. Then also, we looked at the common populations who are at risk. And then, of course, we talked about the lessons that has been learned, particularly from Uganda. And clearly, you see that if we have an existing response system, the country is able to respond very rapidly. And it also brings to fore about leveraging that, the system that has been developed for HIV in terms of sample transport, testing, and all that are actually being utilized to respond to the Mpox. Then there was also the presentation on vaccination equity. And for us to address the challenge that we have today, given the context, and it was mentioned that currently only one type of vaccine is available, and that's the one from Bavarian Nordic, that's MVABN. And it's important that we have a phased approach to stop our outbreaks. And the phased approach first will target the contacts, healthcare workers, and key populations. And then, of course, we looked at, discussed immunocompromised infants and breastfeeding women. And of course, for these populations, the non-replicating vaccine is preferred. Now, I really want to say a big thank you to all our presenters and then participants. I think we have about 1,200 people who registered and 300 actively participated. For the participants, we are going to send you the link via email where you have the recording and then the presentation. And then also as an announcement, please note that ICASA 2025 will take place in Accra, Ghana from the 3rd to 8th December 2025. And we expect to see all of you there. Finally, I want to say a big thank you to the Society for AIDS in Africa and the World Health Organization to put this very, very informative session together. I hope you have found it very useful in our efforts to prevent outbreaks and contain transmission on the continent. Thank you very much once again, and the meeting is adjourned. Thank you.
Thank you, Prof. Congratulations. It was a great meeting.
Yeah, very wonderful. Yes.
We really
Thank you
appreciate
very
it.
much.
Yes.
Thank
This
you very much,
was
Professor.
really very good. Very, very,
Yeah.
very good.
Yeah.
We have all
Thank you.
learned something. Yes.
Thank you for inviting me.
Yes. This was
The
very
pleasure,
good.
Dr. Julien.
Yeah,
We
thank
hope
you.
to do the same thing again next year. The first quarter of next year, we have to do something like that again, to sensitize more people.
Okay,
Thank you
I
so
think
much,
you
Prof,
can.
for your valuable time. Thank you.
Yes, you're welcome. Thank you.
Thank you very much, colleagues.
Thank you.
You're welcome, Dr. Alba. Thank you so much.
Thank you so much. Thanks, Luke.
Thank you, David.
Thank you.
Please, can you exit, please? Thank you, Mr. President. Thank you all. Felix, can you exit, please?